Hello everybody, Steve Zuckerman in Baton Rouge, going to expose you to a little discussion on meningitis. Since we just had a patient in the hospital with this, I was inspired to prepare this little discussion. Now, meningitis, as everybody knows, can be caused by a bunch of different pathophysiological mechanisms. The one that we're going to go into a little bit of detail is infectious, whereas we're going to leave any neoplastic autoimmune disorders or medication-induced inflammation of the meninges to some other time. The anatomy, people don't realize this, but neurologists are obliged to include at least one anatomy slide in any discussion that they may be in charge of, or else we could lose our neurological licensees. But in this case, we're talking meninges, which has three layers. The outer layer is the tough one, the dura, and then the two inner layers are the subarachnoid and pia, which together comprise the leptomeninges, which is where infections usually occur, though in more chronic cases and in those granulomatous meningitis, the dura can also be involved. And clinically, one can see evidence for meningismus, which traditionally was tested for by the use of either Koenig's or Brudzinski's or both. But the last time either of those mechanisms or maneuvers have been done in our hospital is, who knows. But Koenig's test was when you flex the hip to 90 degrees and then extend the foot out, it will cause pain, and usually the patient will bring their neck up. And Brudzinski's is the opposite kind of, in that you flex the neck and it causes flexion of the hips and the knees. Now, these were supposed to be very specific signs, but not sensitive, only present in 30 to 60% of patients found to have meningitis, and not very reliable. So, in this discussion, we're going to distinguish between acute meningitis and chronic meningitis. Of course, the difference being the time frame of the actual illness itself, whereas an acute meningitis, which is usually bacterial or viral, there's just a couple of days of onset before they come to the hospital. Whereas in a chronic meningitis, by definition, there has to be symptoms for at least 1 month before it's considered to be a chronic meningitis. If there is concomitant confusion with the acute meningitis, it's deemed to be meningoencephalitis, whereas cognition in the chronic cases is not unusual, but other features may be present as well, such as strokes or cranial neuropathies or venous sinus thromboses as a result of the chronic inflammatory process which is taking place in the meninges. So, what do we do with suspected meningitis? Well, of course, we obtain spinal fluid. Sort of a barbaric tradition, but it's very useful. And what we look for is the presence of low glucose, which is deemed to be hypoglycemia, which means that the spinal fluid glucose is less than 40% of the serum glucose. Now, theoretically, the serum glucose should be obtained an hour before the spinal tap so as to enable an equilibration of the glucose from the serum to the CSF, but in practical purposes, they can be obtained at the same time. So we see low glucose, usually in bacterial and fungal or tuberculosis meningitis, sometimes in viruses, and not infrequently in non-infectious causes such as neoplasms or sarcoidosis, or even a subarachnoid hemorrhage. Then we measure the protein. Normal is less than 35 milligrams per deciliter, and if it's elevated, it represents a breakdown of the blood-brain barrier, and it is seen typically in bacterial meningitis and in the granulomatous meningitis. And then, of course, we look at these cells. We look at the number of cells and the type of cells that are present in the spinal fluid. Usually in bacterial, you'll see greater than 500 or 1,000 polymorphonuclear cells, whereas in a viral meningitis, you'll see less, and you'll tend to see lymphocytic predominance, though early on in a viral illness, they can actually be polymorphonuclear. And in the case of fungal or TB, you'll see lymphocytes with the low glucose, and here's a little helpful chart which puts all of those details together. Bacterial meningitis greater than 500 with polymorphonuclear, with low sugar, viral, normal sugar, usually up to 500, maybe lymphocytic predominance, and granulomatous, again, low protein, low glucose, and lymphocytic predominance. So that helps you distinguish pretty readily, but there's been a newer test that we're all familiar with, and it's called the BioFire Film Array Meningitis Encephalitis Panel, which is what you get back when you order from the spinal fluid. And drilling down into that, we see that it tests for the most common both bacterial and viral pathogens that are seen. So the most common bacterial cause of meningitis is Strep pneumococcus, which is very well represented here and very sensitive for that. Neisseria meningitis, also seen. Haemophilus influenza used to be the third, used to be most prominently in pediatric age group, but with the onset of inoculations, and parents aren't opposed to the vaccinations for this, it's very rare. But we also check for E. coli and strep. Now, the strep we see a lot of times in people who've had splenectomies. Neisseria in immunocompromised, and in the field of neurology in particular, there is a monoclonal antibody called eculizumab, which is used for myasthenia gravis and for neuromyelitis optica, Devic syndrome. It's an anti-complement medication, and it leaves the patient 1,000 to 2,000 times greater at risk for meningitis, and so it's incumbent that they get vaccinated again before they get that medication. And in terms of the viruses, the most common viruses are going to be the varicella zoster virus and the herpes simplex 1 and 2, and these are well represented in this panel. Now, one little comment about the fungus that's here, the Cryptococcus, both neoformans and gattai. It is covered, but not as well as ordering a separate cryptococcal antigen on the spinal fluid. So if that is within your differential, Cryptococcus, then you shouldn't rely on the results of this panel, since it's only positive about 50% of the time, whereas if you check it independently or singly as an antigen level, it'd be positive 90 to 95% of the time. So there are limitations of this panel. One is it doesn't cover arboviruses, so that West Nile virus is not detected. So if it's a summer season and if there's a West Nile virus outbreak going around, you should order it separately as a West Nile virus IgM. And we just recently had a patient, unfortunately, who had multiple myeloma, and he had meningitis, an encephalitis, and a flaccid paralysis, to the extent that he couldn't move a muscle, and we couldn't determine his degree of cognition, but he had a very bad case. And the other drawbacks of the panel are that, again, the cryptococcal antigen is not the greatest. Sometimes herpes simplex 1 and 2 should be tested for as independent immunoglobulins, and it doesn't test for a lot of the chronic meningitis, tuberculosis, syphilis, Lyme disease. It doesn't cover staph or gram-negative rods. But keeping those limitations in mind, it's been a very useful panel and obviates the need for any sort of viral culture, since most of them are detectable by PCR. Now, Ken mentioned that there is another new wave, metagenomic testing, which is currently undergoing evaluation as to its clinical applicability, in which any sort of non-human DNA can be assessed, can be identified and replicated and hopefully identified, but the applicability in clinical practice has yet to be established for the metagenomic testing. So, the 4 features of meningitis, there is a tetrad. It's fever, headache, stiff neck, and confusion. Now, if you were to try and depend on the presence of all 4 of these in order to diagnose meningitis, you would miss 55% of meningitic patients, if that's a word. But if you have a high index of suspicion and your patient demonstrates 2 of these 4, you'll pick up about 90% of all people who have meningitis. So don't be so restrictive in what clinical features you require in order to consider that diagnosis. So when somebody comes to the emergency room and you think they may have meningitis because of their symptoms and features, what do you do first? Well, you order antibiotics, because it's well known that the outcome of the treatment of meningitis depends on how rapidly the first dose of antibiotics can be administered. So you don't wait for anything else to come back. If you think that they have meningitis, you go ahead and order the antibiotics, and we'll talk in a minute about which ones to order. Next thing you do, you get blood cultures. About 70 to 80% of people with meningitis will have abnormal blood cultures, giving you the organism and its sensitivities, whereas you may not get that information from the spinal fluid. So that's the second thing you do. Third thing, hopefully your antibiotics are back because you work at the Veterinary General Hospital, and you administer the antibiotics. And then finally, you get your spinal fluid after you've gotten the cultures and given antibiotics. And then the question becomes, do you require a CT scan of the brain in order to get the spinal fluid? And the rule is you don't wait to get the spinal fluid again. And so you don't wait before the patient goes to CT and comes back, etc., and goes to get the spinal tap. You give the antibiotics. You have at least a 2-hour window between when giving the antibiotics and obtaining the spinal fluid is affected by those antibiotics. So it gives you a pretty large window. And in general, you don't need to get a CT scan if the patient is awake and alert. The only times that it is needed to get a CT before the LP is if the patient has a reduced level of consciousness, they have focality on their examination or papilledema, if they present with seizures, or in an immunocompromised individual, then CT scan is necessary prior to the spinal tap to make sure that it would be safe and you would not induce a herniation. Again, CT scan should not delay the administration of your antibiotics. And the initial regimen that you're going to give reflects those organisms which are most common. So strep pneumonia, Neisseria meningitis, etc. So you give vancomycin because a lot of the strep is resistant, and so you have to give the vancomycin, and you give a third generation cephalosporin, either ceftriaxone or cefotaxime. It's also under guideline to give concomitant or even beforehand dexamethasone 10 milligrams every 6 hours for 4 days. This has been proven to help prevent complications of meningitis, such as focal complications or hearing loss, and in particular in the strep category. If they don't have strep, a lot of people discontinue the dexamethasone. Now, in addition to the vancomycin and the third generation cephalosporin, if your patient is also of advanced age like myself, or alcohol user, which is not like myself, or immunosuppressed, you got to cover listeria with ampicillin. And then in the case of patients who have had neurosurgical procedures, you have to add an anti-pseudomodal beta-lactam, such as cefepime, ceftazidime, or meropenem. And that covers the coverage. And again, with the common organisms, the duration of treatment, group B strep is 14 to 21 days, listeria 21 days, and the other ones are either 10 or 10 to 14 days. Now, turning to viral meningitis. Again, our West Nile is not on the PCR test and has to be ordered separately. The ones that are most common are going to be varicella zoster and the herpes simplex 2, which can come from a genital herpes. If the HSV2 isn't cleared out, it can cause recurrent meningitis, also known as Mollaret syndrome. Varicella zoster can be focal, it can be a generalized meningoencephalitis, and it gets treated with acyclovir and then oral valcyclovir. However, varicella zoster is also known to cause a delayed vasculitis, in which case the varicella zoster should be checked for independently in the spinal fluid and not from the panel, and can be very bad. Now, turning our attention to the chronic meningitis, breaks down into either infectious, which we'll talk about in a second, or non-infectious. And in the non-infectious category, we see either neoplastic or autoimmune disorders. And so the workup has to entail a lot more, and a lot more evaluation of the spinal fluid, looking for neoplastic cells. And the rule of thumb is that you may require up to 3 LPs, each with a high volume of each, and assessing the CSF with cytometry and flow cytometry, looking for those types of cells. And if those are negative and you have a high suspicion for a neoplasm, we look for a primary source with imaging, either a PET scan or CT scan of the chest, abdomen, and pelvis. The autoimmune disorders, you can check these blood tests, two of which I had never heard of before I read the article. One is called citric citrullonated peptide, which apparently diagnoses rheumatoid arthritis, the ANCA, and IgG4. So we still use the same standard tests that we did before, and we look for those chronic infectious diseases, and we'll talk about those next. One being the fungus. Again, you got to check separately the cryptococcal antigen, and if all else fails, you have to look at all the others: blastomycosis, coccidiomycosis, all depending on geographic location and setting of the infection. HIV can cause a chronic meningitis, particularly when they're seroconverting, and so their HIV test in and of itself may actually be negative, so you look for viral loads. Lyme disease, Borrelia burgdorferi, again, you got to be in the right geographic area, which we are not. Perhaps seeing the skin manifestations, chronic migraines, and looking at spinal fluid and serum for Lyme titers. Neurosyphilis used to be pretty common. I think it is less common nowadays, but seen not infrequently in immunocompromised or HIV individuals. And it can take several different forms, as we know. Meningovascular is the one we're looking for chronic meningitis. Other forms of neurosyphilis include a focal nerve infection called a gumma, tabes dorsalis, and a dementia. The typical Csf findings are going to be some pleocytosis, and one looks for the presence or absence of either non-treponemal VDRL or RPR in the serum, and which is almost present 100% of the time, but is only present maybe 30 to 60% of the time in the spinal fluid itself. And so if you're really looking to make the diagnosis, the FTA and the CSF should be looked for. If the patient has a previous history of neurosyphilis which was treated, the FTA may still be positive. So you look for the other parts of the spinal fluid to see whether there is evidence for ongoing inflammation. And then finally, tuberculosis meningitis. This was not uncommon in the early days of AIDS, and we saw young people come in with strokes or cranial neuropathies because this usually affects the basilar meninges, and where those blood vessels go into the brain or where those cranial nerves come out can be involved in the inflammatory infectious process, causing problems. But they would also have headaches, fevers, and confusion, and it was a big problem. The other infectious one would be, of course, Cryptococcus, which again is not best diagnosed by the PCR, but when diagnosed is treated with amphotericin and fluconazole, and the most common complication of that infection would be raised intracranial pressure, requiring either serial spinal taps or even an external drain. And having sat through all that, you're to be congratulated. I don't know if you got anything out of it, but I sure did. Thanks for listening. Bye-bye.